The heart attack patient was coding in the elevator between floors, and the young resident was panicking. The patient transport worker glanced at the monitor, made a split-second assessment, and performed a procedure that saved a life. That's when everyone realized their simple transport guy had skills that belonged in an operating room. Welcome to Interesting Human Stories. Before we dive into this gripping tale of hidden expertise and second chances in the world of medicine, tell me in the comments what city you're watching from today. And if you believe that healing hands never truly lose their power, hit that subscribe button. These stories remind us that medical knowledge transcends job titles. Metropolitan General Hospital's patient transport department operated around the clock, moving patients between floors, departments, and treatment areas with the precision of a well-coordinated logistics operation. The work required physical stamina, attention to detail, and most importantly, the ability to provide comfort and reassurance to people during some of the most vulnerable moments of their lives. David Kim had been working in patient transport for 4 years, arriving each morning at 6 a.m. to begin his shift moving patients throughout the 800-bed medical center. At 49, he carried himself with the quiet dignity of someone who understood that his role, while unglamorous, was essential to the hospital's daily operations. His colleagues in transport knew him as reliable, compassionate, and unusually knowledgeable about medical procedures for someone whose job description involved pushing wheelchairs and gurneys. David had a way of calming anxious patients, explaining procedures in language they could understand, and anticipating the needs of medical staff in ways that suggested more than casual familiarity with hospital operations. The nursing staff appreciated David's gentle manner with elderly patients and his ability to position people comfortably for procedures. The residents and attending physicians barely noticed him, focused as they were on diagnoses, treatments, and the constant pressure of medical decision-making. What none of them knew was that Dr. David Kim had spent 15 years as one of the region's most respected interventional cardiologists, with over 3,000 successful cardiac procedures to his credit and a reputation for saving patients that other surgeons had written off as hopeless. David's medical career had begun with the idealism that drove many people toward healing professions. Born to Korean immigrant parents who'd sacrificed everything for their children's education, he'd excelled in pre-med studies and been accepted to Johns Hopkins Medical School, where his natural aptitude for cardiovascular medicine had been recognized early. His residency in internal medicine had been followed by a prestigious fellowship in interventional cardiology at Massachusetts General Hospital. By age 35, David had been recruited as an attending physician at Metropolitan General, where he'd built a thriving practice, specializing in complex cardiac interventions, procedures to open blocked arteries, repair damaged heart valves, and restore normal cardiac function to patients facing life-threatening conditions. David's success had been built on a combination of technical skill, diagnostic intuition, and an almost obsessive attention to detail that had made him one of the most trusted cardiologists in the city. His patients had ranged from young adults with congenital heart defects to elderly individuals whose aging hearts required delicate interventions to extend their lives. But cardiac surgery, particularly interventional procedures, carried inherent risks that even the most skilled physicians couldn't eliminate entirely. The margins between success and catastrophe were measured in millimeters and seconds, and every cardiologist knew that despite their best efforts, some patients wouldn't survive the procedures intended to save them. The case that had ended David's surgical career had involved a 67-year-old construction worker named Robert Martinez, who'd suffered a massive heart attack and been brought to Metropolitan General in critical condition. Multiple arteries were blocked, the heart muscle was damaged, and the patient's chances of survival without immediate intervention were essentially zero. David had performed the emergency cardiac catheterization with his characteristic precision, threading tiny instruments through blood vessels to reach the blocked arteries around Robert Martinez's heart. The procedure had gone exactly as planned. Blocked vessels were opened, blood flow was restored, and the patient's vital signs had stabilized. But during the recovery period, an unexpected complication had developed. A small section of artery that had appeared stable during the procedure had suffered what cardiac surgeons called a delayed rupture, a tear in the vessel wall that occurred hours after the intervention, causing internal bleeding that was difficult to detect until it became life-threatening. David had recognized the problem immediately when Robert's blood pressure had begun dropping and his heart rhythm had become irregular. Emergency surgery had been performed to repair the damaged artery, but the patient had suffered brain damage from oxygen deprivation during the period when his circulation had been compromised.
Robert Martinez had survived, but with significant cognitive impairment that had ended his career, strained his marriage, and fundamentally altered his family's life. The medical review board had determined that David's technique had been appropriate and that the complication was an unfortunate but recognized risk of the procedure, but the malpractice lawsuit that had followed had been devastating, both financially and emotionally. Robert's family had argued that David should have anticipated the risk of delayed rupture and taken additional precautions. Expert witnesses had disagreed about whether different techniques might have prevented the complication. The legal proceedings had stretched over 3 years, during which David's every professional decision had been scrutinized by lawyers, expert witnesses, and medical review boards. His malpractice insurance had covered the financial settlement, but the psychological cost had been immeasurable. More damaging than the legal challenge had been the gradual erosion of David's confidence in his surgical abilities. He'd begun second-guessing decisions that had once been intuitive, hesitating during procedures where decisive action was required, and experiencing anxiety attacks during complex interventions. His colleagues had been supportive initially, understanding that malpractice litigation was an occupational hazard that could affect any surgeon. But as David's performance had continued to decline, influenced by anxiety and self-doubt, the hospital administration had quietly suggested that he might benefit from a leave of absence. The leave had stretched into months as David had struggled with depression, insomnia, and the crushing realization that the career he'd spent 20 years building was no longer sustainable. The hands that had once moved with surgical precision now trembled when he held instruments. The diagnostic confidence that had saved thousands of lives had been replaced by paralyzing uncertainty. Eventually, David had made the painful decision to surrender his medical license voluntarily rather than risk additional patients being harmed by his deteriorating performance. The man who had once been introduced as one of the city's leading cardiologists had become simply another former physician whose career had ended not in retirement or recognition, but in legal battles and self-doubt. The job in patient transport had been suggested by Dr. Patricia Chen, David's former colleague in the cardiology department, who had maintained contact during his darkest period. The position allowed David to remain in the medical environment he'd known for decades while avoiding the responsibilities and liabilities of patient care. "You know this hospital better than anyone," Patricia had told him. "The transport department needs people who understand medical procedures, who can interact appropriately with patients, and who won't be rattled by emergency situations." The work had been humbling initially. After 20 years of being addressed as Dr. Kim and consulted on life-and-death medical decisions, David had become simply David from transport, responsible for moving patients between departments and ensuring they arrived safely at their appointments. But gradually, David had discovered unexpected satisfaction in the role. Patient transport required different skills than cardiac surgery, but they were skills that utilized his medical knowledge and his natural compassion for people facing health crises. He'd learned to read subtle signs of patient distress during transport, to position people comfortably despite medical equipment and mobility limitations, and to provide the kind of reassurance that helped anxious patients cope with unfamiliar and frightening medical procedures. The call had come at 2:17 p.m. on a Tuesday afternoon. Emergency transport needed for a patient in the cardiac catheterization lab who required immediate transfer to the intensive care unit. David had responded quickly, arriving at the cath lab to find a 58-year-old woman named Linda Peterson who'd suffered complications during what should have been a routine procedure to evaluate chest pain. Linda had been conscious but clearly in distress, with elevated heart rate and blood pressure that indicated ongoing cardiac problems. Dr. Jennifer Walsh, a second-year cardiology resident, had been accompanying the patient to ensure continuous monitoring during transport. The elevator ride to the ICU should have taken less than 3 minutes, but halfway between the 4th and 5th floors, Linda Peterson had gone into cardiac arrest. Her heart rhythm, visible on the portable monitor, had deteriorated from irregular beats to the chaotic pattern that indicated imminent death without immediate intervention. Dr. Walsh had begun CPR immediately, but her movements had been uncertain, influenced by the stress of dealing with a life-threatening emergency in the confined space of a hospital elevator. The portable defibrillator had been available, but the young resident had hesitated, uncertain about the appropriate settings for someone with Linda's underlying cardiac condition. David had been positioned at the head of the gurney, nominally there to assist with transport, but actually observing the cardiac emergency with the trained eye of someone who'd managed thousands of similar crises during his surgical career. When Dr. Walsh had looked up from her CPR efforts with panic in her eyes, David had made a decision that would expose his medical background but potentially save a life. He'd quietly moved to the defibrillator, adjusted the settings to account for Linda's body weight and underlying cardiac condition, and positioned the paddles with the precision of someone who'd performed countless cardiovascular resuscitations. "On my count," David had said calmly, "1, 2, 3, clear." The electrical shock had restored Linda's heart rhythm to a stable pattern, and her blood pressure had returned to acceptable levels. But more significant than the successful resuscitation had been Dr. Walsh's recognition that David's actions had demonstrated medical knowledge far beyond what a patient transport worker should possess. "How did you know to adjust the Joule settings?" Dr. Walsh had asked as the elevator reached the ICU and Linda had been transferred to intensive care monitoring. "Experience," David had replied simply, hoping to avoid further questions that would inevitably lead to explanations he wasn't prepared to give. But Dr. Walsh had persisted. "That was perfect ACLS protocol, adjusted for her cardiac history. You positioned the paddles exactly right, timed the shock perfectly. Where did you learn advanced cardiac life support?" David had hesitated, knowing that his answer would either require lying to a colleague or revealing background information that would complicate his carefully maintained anonymity. Over the following days, word had spread through Metropolitan General's cardiology department about the patient transport worker who'd helped save Linda Peterson's life. Dr. Walsh had mentioned the incident to her supervising physician, who had asked discreet questions about David's background and medical knowledge. Eventually, Dr. Patricia Chen had been approached by the cardiology department chair, Dr. Robert Anderson, who had recognized David's name and remembered his former colleague's distinguished career and difficult departure from active practice. "Is that the same David Kim who used to be on our cardiology staff?" Dr. Anderson had asked Dr. Chen privately. "Yes," she'd replied. "He's been working in patient transport for the past 4 years. It's been good for him, allows him to stay in medicine without the pressures of direct patient care." Dr. Anderson had requested a meeting with David, which had taken place in the cardiology department conference room during David's lunch break. The conversation had been awkward initially, with David uncertain about whether his intervention in Linda Peterson's emergency had violated hospital protocols or created liability issues. "David," Anderson had said, "I want to discuss what happened with the elevator emergency. Dr. Walsh described your actions as textbook advanced cardiac life support, performed with expertise that saved the patient's life." David had nodded quietly, waiting for criticism or questions about whether he'd overstepped his role as a transport worker. Instead, Dr. Anderson had made an offer that would change David's trajectory once again. "We're expanding our cardiac rehabilitation program," Dr.
Anderson had explained, "and we need someone with your combination of clinical knowledge and patient interaction skills. The position would be as a cardiac rehabilitation specialist, working with patients who are recovering from heart attacks, cardiac procedures, and heart failure. The role would allow David to use his medical knowledge without the surgical responsibilities that had become impossible for him to manage. Cardiac rehabilitation involved educating patients about heart-healthy lifestyle changes, monitoring their progress during supervised exercise programs, and providing the kind of medical support that could help prevent future cardiac events. It's not surgery," Dr. Anderson had acknowledged, "but it's meaningful medical work that could help hundreds of patients every year." David had been tempted by the offer, but also terrified by the prospect of returning to direct patient care. "I'm not sure I'm ready for that level of medical responsibility," he'd admitted. "The patients who saved Linda Peterson's life suggests otherwise," Dr. Anderson had replied. "Your instincts are intact, your knowledge is current, and your compassion for patients is obvious to everyone who works with you." David had asked for time to consider the offer, but privately he'd been struggling with conflicting emotions about returning to medicine in any formal capacity. Part of him longed to use his training and experience in meaningful ways, while another part was terrified of making mistakes that could harm patients. The decision had been influenced by a conversation with Linda Peterson herself, who had requested to meet David after learning that the transport worker had played a crucial role in saving her life. The meeting had taken place in the hospital's cardiac rehabilitation center, where Linda had been participating in the exercise program designed to strengthen her heart after her procedure. "I wanted to thank you," Linda had said simply. "The doctors told me what you did in that elevator. Without your help, I wouldn't have survived to see my daughter graduate from college next month." David had been moved by her gratitude, but also reminded of the positive impact that medical knowledge could have when applied appropriately. "I'm glad I could help," he'd replied. "Are you really just a transport worker?" Linda had asked. "The way you handled that emergency, it seemed like you had extensive medical training." David had found himself explaining his background. his former career as a cardiologist, and the circumstances that had led to his transition to patient transport. Linda had listened without judgment, understanding that careers in medicine could end for reasons beyond a physician's control. "So you gave up medicine because of one complication?" she'd asked. "It wasn't just one complication," David had explained. "It was losing confidence in my abilities, being afraid that I might harm someone else." Linda had considered this carefully. "But you saved my life. Doesn't that suggest that your abilities are still intact?" David had accepted Dr. Anderson's offer to join the cardiac rehabilitation program, beginning work as a specialist in helping patients recover from heart disease and cardiac procedures. The role had allowed him to utilize his extensive knowledge of cardiovascular medicine while focusing on education, prevention, and rehabilitation rather than invasive procedures. The work had been rewarding in ways that David had forgotten were possible. Instead of the high-stress environment of the cardiac catheterization lab, he'd worked with patients over months of recovery, helping them understand their conditions, modify their lifestyles, and regain confidence in their body's ability to heal. His first patient had been Linda Peterson, who had specifically requested to work with the man who'd saved her life. Under David's guidance, she'd progressed from barely being able to walk across a room to completing supervised exercise sessions that had strengthened her heart and improved her overall health. "You've given me my life back twice," Linda had told David during one of their sessions. "Once in that elevator, and again by helping me get strong enough to live independently." Word had spread quickly through Metropolitan General about the former cardiologist who'd returned to medicine as a rehabilitation specialist. Other departments had begun referring their most complex cardiac patients to David, knowing that his combination of advanced medical knowledge and patient compassion made him uniquely qualified to help people navigate the challenges of heart disease. 6 months after Linda Peterson's cardiac arrest, David had found his place in medicine again, but in a role that was different from his previous career as an interventional cardiologist. The cardiac rehabilitation program had expanded under his leadership, helping dozens of patients recover from heart attacks, bypass surgeries, and other cardiac procedures. His approach had been influenced by his own experience of losing and regaining confidence. David had understood viscerally what it meant to doubt your body's ability to function normally, to fear that any exertion might trigger another cardiac event, to struggle with depression and anxiety following a life-threatening medical crisis. "Recovery isn't just about strengthening your heart muscle," David would tell his patients. "It's about rebuilding confidence in your body's ability to heal and your own ability to live fully despite having a cardiac condition." The program had attracted attention from other hospitals, and David had been invited to speak at cardiology conferences about innovative approaches to cardiac rehabilitation. He declined most speaking opportunities, preferring to focus on direct patient care rather than professional recognition, but privately, David had found peace with his career transition. The work wasn't as technically challenging as interventional cardiology, but it was more personally meaningful than his previous surgical practice had been. Instead of seeing patients for brief procedures and follow-up appointments, he developed relationships with people over months of recovery, watching them regain their health and confidence. 2 years after the elevator emergency that had changed his life again, David had reflected on the path that had brought him from surgical practice to patient transport to cardiac rehabilitation. The journey had been painful, marked by professional failure and personal crisis, but it had ultimately led to work that was more aligned with his values and temperament. Robert Martinez, the patient whose surgical complication had ended David's career as a cardiologist, had contacted him after learning about his new role in cardiac rehabilitation. The conversation had been difficult but healing for both men. "I don't blame you for what happened," Robert had said during their phone conversation. "Complications happen in medicine. I understand that now. What matters is that you found a way to keep helping people." David had been moved by Robert's forgiveness and understanding. The conversation had helped resolve some of the guilt and self-doubt that had haunted him since the malpractice case. "I think about you every day," David had told Robert. "What happened to you changed how I practice medicine, made me more careful, more aware of the human cost of complications." "Then maybe something good came from it," Robert had replied. "If you're helping other people avoid what I went through or recover better than I did, then my experience meant something." Dr. David Kim continues to work in cardiac rehabilitation at Metropolitan General Hospital, where he's become known for his innovative approach to helping patients recover from heart disease. His combination of advanced medical knowledge and personal understanding of career setbacks has made him uniquely effective at helping people navigate both the physical and emotional challenges of cardiac recovery.
The patient transport department still remembers David as the colleague who'd brought medical expertise and compassion to their work. Several transport workers have mentioned his influence on their approach to patient care, and some have been inspired to pursue additional medical training. Linda Peterson has made a complete recovery and regularly volunteers with the Cardiac Rehabilitation Program, helping other patients understand that heart disease doesn't have to limit their ability to live full, active lives. She credits David not just with saving her life, but with showing her how to rebuild her confidence after a life-threatening medical crisis. David's story has spread quietly through Metropolitan General's medical community, inspiring discussions about how physicians can continue serving patients even when their original career paths become unsustainable. Several other doctors facing similar transitions have sought his advice about alternative ways to use their medical knowledge. The elevator where Linda Peterson's cardiac arrest occurred has been equipped with upgraded emergency equipment, partly based on David's recommendations about what interventions are most critical during transport emergencies. His experience has influenced hospital policies about medical support during patient transfers. Most importantly, David has found peace with his role as a healer who works outside the operating room. The hands that once performed complex cardiac procedures now guide patients through exercise programs and lifestyle changes. The diagnostic skills that once identified surgical solutions now help people understand their conditions and participate actively in their recovery. David Kim may no longer perform heart surgery, but he continues to heal hearts, not just the physical organ, but the emotional and psychological aspects of cardiac recovery that are equally important for long-term health. From the prestigious world of interventional cardiology to the humble role of patient transport, and finally to meaningful work in cardiac rehabilitation, David's journey shows us that medical careers can evolve in unexpected directions while still serving the fundamental goal of healing. Sometimes the most important surgery is performed not in an operating room, but in the careful reconstruction of a career, a purpose, and a calling that survives even the most devastating professional setbacks. So now I ask you, have you ever encountered unexpected medical expertise in someone whose current job didn't reflect their training, someone whose careful attention to patients suggested knowledge beyond their apparent role, someone who found new ways to heal after their original path was blocked? Share their story in the comments, because here at Interesting Human Stories, we believe that the calling to heal transcends job titles and professional setbacks. It finds new expressions in every act of medical compassion, every moment of patient care, every decision to use knowledge in service of others' well-being. If this story moved you, subscribe and share it. Help us honor the healthcare workers who continue healing long after their circumstances have changed, who find new ways to serve patients despite professional obstacles. We'll see you in the next story. Until then, remember, the person pushing your wheelchair, checking your vital signs, or helping with your recovery might be carrying more medical knowledge and healing wisdom than you could imagine.